Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. I'm joined today by our deputy editor Nick Bostock to talk about some of the key news stories affecting general practice. Coming up, we'll be discussing what last week's spending review had to say about the NHS and looking ahead to what we know about the government's 10-year health plan, which is expected to be published imminently. We'll be discussing what the plan could mean for the future of general practice in the NHS in England and how the government might aim to meet its ambition of creating a neighbourhood NHS and bringing back the family doctor. Our good news story this week is about those GPs who received honours in the King's Birthday Honours last weekend. That's all to come on this episode of Talking General Practice. So hi Nick, we're going to be talking about the 10-year plan for most of this episode, but ahead of that I thought it was worth discussing the government's spending review which happened last week, because that has effectively set out the budget that the NHS has to deliver on this plan.
Yeah, the NHS was the big winner from the spending review, wasn't it? You were looking at that, Emma, so what did the government say?
Yeah, so the general consensus was that health alongside defence was the big winner from the spending review. So the spending review was setting out the government plans for day-to-day spending and capital investment for the next few years. The government had already set out spending for this financial year, so for 2025-26. So the spending review was to set out budgets for day-to-day spending until 2028-29 and capital investment up until 29-30. So capital investment, that's the funding for things like buildings, IT and infrastructure. So Chancellor Rachel Reeves announced that the NHS would receive a 3% average annual increase day-to-day spending. So funding would rise by £29 billion a year in real terms by the end of that period, so by 2028-29. It's worth mentioning that while she was announcing this in the Commons, Reeves said that the increase would shift care to the community and provide funding to support the training of thousands more GPs so that they could deliver more appointments. Obviously, absolutely zero detail on that at the moment, and it's not really clear, where these GPs would work even if they were trained. So the government plans to invest up to £10 billion in NHS digital transformation over the next 3 years, but it's a less good picture on capital investment more generally. The government said that spending will increase by £2.3 billion a year in real terms by 2029-30 compared to 2023-24, but most of that increase has already happened. So basically capital budgets are basically going to remain flat for the next 4 years. I suppose one thing worth highlighting is that the document that accompanied the spending review said that the extra money for the NHS would come with reform to deliver better care. The government says it expects the funding to enable the NHS to deliver 2% productivity growth each year, which it says will save £17 billion over the 3 years of the spending review, all of which will be reinvested in health. But, there's a lot of pressure on delivering those productivity gains, and there's always a lot of talk about how we could improve productivity in the NHS and how much money that would save us. But there's not really been much progress on that in the past, and that 2% productivity increase, I think, is a big ask. Obviously, the reforms the government is talking about is these shifts from hospitals to community, analogue to digital, sickness to prevention, and the 10-year health plan, which is due imminently, will set out what those reforms will look like. And we're going to talk about that in a bit more detail in a bit. One other thing to note about all of this is that 3% increase, a year increase, is bigger growth than the NHS has seen in recent years, but it's actually below the historic average annual growth, which the Nuffield Trust think tank put at about 3.7% a year between 1979 and 2020. So it's a lower than average increase in funding.
So what's the general reaction to all of this from people in the NHS? Is it enough? Is it going to deliver the changes that the government wants?
Bit of a mixed bag, I would say. I mean, I think the fact that health did better than many other departments, obviously everyone welcomed that. Could have been a lot worse. Some other departments have got basically no kind of real increase over the next couple of years. But, commentators were very cautious, and economists, people who know lots about these sorts of things, were very cautious about whether even that was going to be enough funding for the government to deliver on the things that it said it wants to do. The RCGP, for its part, said the announcements of thousands more GPs would be good news for patients and basically would set the path for improving general practice. But obviously, the college wants to see more details on how that funding will work, what the workforce numbers look like, and some kind of guarantee that, there's going to be jobs for those GPs after they've trained. There's really big concern that the cohort of GPs due to qualify this summer could struggle to find a job. And we've talked about that before. So there's no point training all these GPs if there's no jobs for them. The Institute for Fiscal Studies, or the IFS, who are the real experts in public spending, said that aiming to get the NHS back to the 18-week target for hospital waiting times by the end of this Parliament was hugely ambitious and might not be possible with the money it's been given. The Nuffield Trust said something very, very similar, basically said rising staff costs, including employer national insurance costs, has had a huge impact on the funding increases the NHS received this year. The drive to cut waiting lists, rising costs of drugs, new technology, all of that money the NHS is getting is going to be used up pretty quickly. They also warned that with capital spending remaining flat, it was going to be really difficult for the health service to invest in premises upgrades and the technology it actually might need to deliver those efficiency savings I mentioned. And, there might be some really difficult decisions to make in the coming years about what gets prioritised. The Nuffield Trust also warned that money that's been earmarked for a review of social care over the next few years is unlikely, to really address any of the problems in that sector. And we know there's massive problems there. Worth mentioning, I suppose, the NHS Confederation also said that while the money was positive, the vast majority of that's going to go on staff pay rises and new treatments as well, so same sort of thing. So there's no guarantee that government would be able to hit those waiting time targets. They also highlighted that shortfall in capital funding and talked about the need to lift the ban on private investment to help build more premises. So basically, the 10-year plan is going to have a lot to do, really, if it's going to set out how this funding is going to improve the NHS in a way that's actually meaningful to staff and to patients. Right, so that's the financial pitch for the health service in England for the next few years. So what is the government going to spend all this money on? The spending review is really the backdrop for the government's 10-year health plan. We've been waiting for that since the Labour government was elected almost a year ago. And by all accounts, it sounds like we are just weeks away, perhaps even less, from that being published. Nick, last week was the NHS Confederation Expo conference, which is a major event for NHS managers, policymakers and the like. The 10-year plan was talked about at length in various sessions at that event, wasn't it? We both watched a session where Sally Warren, who is the Department of Health and Social Care official who's been leading on the plan, spoke on a panel. What did she actually have to say about it? I mean, she suggested that the plan will be putting forward a pretty radical overhaul of the health service, didn't she?
There were a couple of standout lines from Sally Warren that gave a sense of how big she expects the shifts to be. She said that if the health service successfully delivered the 10-year plan, a decade from now, the health service would be completely reimagined and that it would look completely different from where it is today. And she described the scale of change set out in the 10-year plan, which, like you said, we're expecting in the next few weeks, as absolutely unprecedented. It's quite a big claim, considering a former NHS chief executive not so long ago described Andrew Lansley's 2012 reforms as so big you could see them from space. But in some ways, maybe those 2012 reforms are part of the reason that this set of changes is being described in these sort of monumental terms, because at least in part, it's about turning back the clock and unpicking the Lansley reforms. A good example of that is that the government wants ICBs to be stripped back to a more strategic role. And as their numbers reduce through mergers over the next year or two, the health service is going to move back to something a lot more like the 28 strategic health authorities that were in place before the Lansley reforms abolished them. The NHS chief executive, Sir Jim Mackey, who's also at this Expo conference, suggested there'd been a lot of iterations of the plan. He nearly said at one point a version, but he managed to stop himself just in time. And he hinted at a bit of frustration with the vision it set out initially being diluted through rounds of consultation and discussion. But he said the focus on neighbourhoods, which we've known for a long time now, would be a major plank of whatever came through in the final 10-year plan. That idea of a more collaborative, integrated approach to delivering NHS services across sort of regional health systems, he felt was a standout feature of the whole plan and something he felt really positive about, despite the sort of dilution that he mentioned. There was another nod from him to the notion of sort of turning the clock back to a pre-Lansley era. He said that neighbourhood plans were something his part of the country, in North East England, had been trying to work towards 10, 15 or even 20 years ago, but that this work had been knocked off course a bit in recent years. We also heard some points that we'll come on to in a minute, about how the NHS hopes to rearrange incentives and funding to try and drive some of the changes the government, the NHS, want to see. So overall, the suggestion is that these changes will be really significant, that there'll be a big focus on neighbourhoods and collaboration, and that in essence there's a policy shift that'll move the health service back to something a bit closer to where it was before 2010. And obviously that's the last time a Labour government was in office.
One of the things I picked up on from what Sally Warren was saying is that, quite keen to stress that this is a 10-year plan, so we're not going to realise all of these massive changes necessarily that quickly. But she also said that the first 3 years of the plan were going to be really important in terms of a foundation for making that progress. Obviously, those first 3 years are effectively the rest of this government's term in office. And so the Prime Minister, the Health Secretary, the Chancellor, they're all going to be really keen to make sure that something concrete happens within that time frame, so that when they go back to the public for the next election, they can say, look, we've improved the NHS, we said we were going to do this, and we have, stick with us, and things will continue to get better. I think, it's also important, and Sally Warren actually made this point, for NHS staff, isn't it? It's important that they can see that things are improving in this first couple of years, so they feel there's a light at the end of the tunnel, and that they're in a system that's starting to make a difference for patients. And I think the other thing to mention is that lots of people stress the importance of workforce in this. Lots of people I saw speaking throughout that conference. Sally Warren talked about the need to build on the strengths of the current workforce and recognise the need to change the workforce over the next 10 years to take advantage of changes to technology. And she talked about having a more flexible workforce. And Jim Mackey, you mentioned him, NHS England's chief executive, said there's going to be a new long-term workforce plan that comes alongside the 10-year plan, although he said that probably wouldn't be out until the autumn. I mean, we know that the RCGP was very critical of the current workforce plan we've got, which was developed under the last government because of its focus on growing the workforce of hospital doctors. But the workforce planning suggested that the GP workforce would basically remain flat. At the RCGP annual conference last year, Wes Streeting very much indicated that those figures would likely be reviewed in a revamped workforce plan. And given what the Chancellor said in the spending review, I think we can expect to see a big change on that when that workforce plan does come out later this year. Nick, Sally Warren also said the plan wouldn't be detailed planning guidance, so that suggests it's going to be much more high-level principles about what's going on. But at the NHS Confederation, you sort of touched on this already, there was a lot of talk about financial flows and how all of that could work. So this is about how you shift money out of secondary care to primary care. Both Penny Dash, who's the chair of NHS England, and Sir Jim Mackey had something to say about that, didn't they? So it seems like there will be some detail in the plan. What do we know about that?
Yeah, there was a really strong acknowledgement from these very senior NHS figures that if they're going to deliver the kind of shift of services from hospital into the community that the government wants to see, there's going to have to be a fundamental shift in how NHS funding flows work, how the incentives to drive those changes work. And that shift in funding flow is going to be crucial too for the neighbourhood NHS model that the government and the NHS wants to deliver. Jim Mackey said there'd be a really strong message in the 10-year plan about collaboration without prescribing specifically who needs to work with whom. He said the plan would be making a big point of the fact that the healthcare system depends on the contributions of many different partners, whether it's the voluntary sector, the NHS organisations themselves, local authorities, the independent sector. And he said that the health service needs to work with everybody and work in the round. And basically, he suggested the plan is going to set out financial reform and changes to incentives to try to drive that shift to neighbourhood care and of services out of hospital. Maybe the standout point he made was that the NHS would break up the block contracts hospitals currently operate under so that it's easier, basically, for funding to go where the work is actually delivered. His line was that if you do something locally in a neighbourhood, you'll get paid for it. You mentioned Penny Dash too, the chair of NHS England, and she made a really similar point. She said the 10-year plan would describe how the NHS would create financial levers to drive the shift of services into the community and more collaboration by reforming incentives and contracts. And she said that getting those contracting mechanisms right would be absolutely crucial to create an environment in which GPs, community services, mental health services, the voluntary sector, bits of hospital services and so on can actually work together effectively. And presumably the point is to avoid creating perverse financial incentives that pull organisations apart rather than enabling them to work together. And she said that has to happen fast in the next year or two. Basically, that comes back to a point you just made, that some impact has to be felt within the current Parliament. So that's now a huge challenge for the health service. Jim Mackey also gave a nod to just how difficult this could be as well. Despite his enthusiasm for the changes that are spelled out in this plan, he pointed out that there's a real anxiety around the fact that the shift to neighbourhoods is something that's been talked about for years and years, but that the health service has never really managed to deliver on. And he said that in the past, trying to move work out of hospitals had often ended up with a duplication of costs. And that's something that just can't happen this time because of the constrained financial position that the NHS is in. I mean, the whole changes to the NHS that we've talked about, the 50% cuts in ICB costs or the merger with the Department of Health, very much driven by the idea of reducing those duplications of cost. So there's a lot riding on this change to financial flows. It's a big shift. It's going to happen really quickly. And the sense is that getting it wrong is something nobody really wants to contemplate.
Health and Social Care Secretary Wes Streeting also spoke there. I mean, it seemed like he went down pretty well in the hall. He was talking about what you've been talking about as well there, completely breaking down barriers between primary and secondary care and mental health and community services. There was an obvious headline from what he said for us about the fact that GPs could end up running hospitals. What exactly did he have to say?
As you said, there was an obvious headline for us from his speech, which was that GPs could potentially take over running hospitals down the line. But that comment was part of a broader point, which was that he wanted the health service to move away from traditional boundaries between, for example, acute services and general practice, expectations about how services should be arranged. So basically a more flexible approach with more innovation and obviously more collaboration, integration. And as part of that, he said he was open to high-performing acute trusts providing community services and primary care, so it could work that way round as well. But he also said that there was no reason successful GPs should not be able to run local hospitals. He sees this working in both directions. So fundamentally, the shift he's talking about is more freedom to innovate and take on more responsibility for successful providers. He actually talked about reinventing foundation trusts as part of this whole theme, the idea of incentives, freedom from central control for providers that deliver successfully. And obviously, again, that's another link back to the pre-Lansley era as well.
Yeah, it's interesting that, isn't it? Because we recently reported on a hospital trust that had handed back its contracts to run GP practices, partly because of this move to a neighbourhood NHS. There was obviously a lot of talk at the conference about how pared back ICBs will fit into this new NHS as well, and what that means for providers. Do we have any sense about how all of this could fit together in reality?
We found out in the ICB blueprint that NHS England published a couple of months ago some of the ways that health service leaders see ICBs changing over the coming months and years. I mentioned earlier about the shift to a more strategic role for ICBs. There's obviously everything we've talked about previously on the podcast around cutting costs by half, the prospect of huge numbers of redundancies, they slim down their workforce and so on. And part of the vision was around shifting bits of the work ICBs currently do down to providers. NHS systems are already making moves towards the neighbourhood-focused system they're expecting the 10-year plan to describe. So we're seeing changes like the one you mentioned. You know, a hospital that was running 3 GP practices has been encouraged to hand those contracts back. And apparently it's because they were fairly spread out, might not fit with the idea of integrating services around geographical neighbourhoods, which could have implications potentially for some PCNs potentially that have not very geographically contiguous sort of formation. We're also seeing other changes. Some areas already have vehicles in place that could enable the shift of some of these ICB functions at scale to providers at community level, but other areas are setting them up. So in Nottinghamshire, the ICB is setting up a GP provider collaborative. That's a structure that some areas already have in place, like I say, which as far as we understand, in Nottinghamshire, the idea is to bring together practices, PCNs, GP federations, potentially organisations like GP cooperatives under one umbrella. not as one organisation, but as a sort of cooperative group, hence the term collaborative. There are still some concerns locally that this sort of structure could ultimately end up taking funding away from practices. And that's something the LMC is really determined not to allow. They want general practice to remain the first choice provider for services commissioned from primary care from general practice. But they also recognise that this sort of structure could be the kind of thing that allows the whole of GP provision across an area to get involved in decisions about how services are commissioned and organised.
Yeah, I think we're going to be hearing a lot about provider collaboration organisations in the next year or so. It seems to be a big area of focus. Another thing Wes Streeting said, which is obviously worth us talking about on this podcast, is that he said he was most proud during his time in office was his work with GPs over the past 11 months. He was talking about the ARRS GP jobs and the contract agreement for this year, wasn't he? What did he actually have to say about that? Why do you think he decided to highlight his work with general practice as a proud moment?
The slightly facetious answer is that he's a bit of a stuck record when it comes to the GP contract and ARRS GP jobs. Pretty much every statement that the government makes about general practice mentions both of those things. So Wes Streeting was never going to miss a chance to highlight them again in a speech to an NHS audience like this one. But ultimately, he's mentioning them because they mark out a major point of difference compared with the previous government. It also actually comes back to a point that you made earlier around showing things that have changed demonstrably during the course of this Parliament. The last government didn't find much new investment for general practice and routinely imposed contract changes. This one has found new investment, albeit with a big caveat about it possibly not being enough and having to weigh it against extra costs, chiefly from the employer national insurance increase. And the contract for 2025-26 went ahead with agreement from the BMA, and that's a really crucial difference. ARS2, the last government promised more GPs and failed to deliver them. It promised it more than once and failed to deliver more than once. But this government saw how the ARRS had successfully brought other staff into general practice in large numbers, and it's used it to create a load of new GP jobs, albeit with caveats around the type of jobs, the pay on offer, the fact that the jobs are open only to newly qualified GPs, and so on. But nonetheless, there on paper, 1,500 new GP jobs created through the ARRS. So that shift is something this government wants to make a big point of, understandably. And perhaps in part that's because having a better relationship with general practice and the medical profession generally is going to be absolutely key, not only to delivering a major GP contract reform over the next couple of years, which they've committed to try and do, but also to delivering the changes to the NHS overall that are going to be described in the forthcoming 10-year plan.
There was another session at the conference which is probably worth us talking about as well, because that was about the future of primary care, which featured NHS England's National Director for Primary Care and Community Services, Dr Amanda Doyle, and NHS England's Medical Director for Primary Care, Dr Claire Fuller, obviously two GPs who will have seen the 10-year plan. I think what was interesting about that, Dr Doyle said that the 10-year plan will be very GP-centric. Not entirely clear what that means. But she did say it would focus on GP access and how to accelerate innovation in this area. Perhaps not a surprise that access will be a big issue, but I think, that's just been the focus of everything coming out of NHS England relating to general practice in recent years. So maybe some GPs will be disappointed that that's potentially where the focus of this is going to be. There's lots of GPs listening to this that would probably say if you want to sort out access, just employ all those GPs who can't get a job at the minute. But there we go. Another interesting line from that talk was that Amanda Doyle said that NHS England was committed to protecting partnerships, but that they also wanted to explore commissioning at scale for services where, a neighbourhood level would be more efficient. So that might come back to where we're talking about those primary care provider collaboratives, maybe a bigger role for GP federations, how this move to ICB's becoming more strategic commissioning role that the government sees them having. They will probably want structures like that in place to commission the community provision of services. You can see, that a key part of ICB's role in the future will be to drive potentially the shift of services out of hospitals into the community, by using those new funding flows and incentives that you've been talking about. But to do that, they're probably going to need to commission across a bigger footprint than just a practice, possibly even bigger than just a PCN as well, so that the service covers the footprint that the hospitals would have delivered it under. So that's perhaps where those primary care provider collaboratives or GP federations could potentially come in. She also talked about what you were talking about earlier, Nick, about PCNs. And, she said that NHS England didn't want to tell them that they had to align with neighbourhood footprints. But there was this sort of suggestion that they actually may need to do that if this was going to work in the most efficient and effective way possible. And that sort of reflects something that was in a London plan for neighbourhood NHS working, which came out a month or so ago. They were talking about the fact that PCNs may need to realign around neighbourhoods. So that might be something we could see coming along as, neighbourhood working becomes more established. The BMA also had something to say about the 10-year plan this week, hasn't it, Nick?
The BMA's message was that the 10-year plan is make or break for general practice, essentially. I mean, it might be make or break for the health service as a whole. This line about the plan's importance for general practice was from the BMA England GP Committee's latest update to the profession. Just coming back to Wes Streeting's line about the success in agreeing a GP contract for the current financial year and what that shows about the government's relationship with the profession, what he didn't mention was that the BMA was unimpressed with the 4% pay rise awarded for this year.
No, I bet he didn't want to highlight that, or the fact that resident doctors are basically balloting on industrial action again. I'm sure he didn't want to highlight those things that are going on.
And I mean, and the BMA said, you mentioned the line about the, bringing back the family doctor. The BMA said, that 4% was not going to bring back the family doctor. And, they said it doesn't do anything to reverse the erosion of GP pay over the past decade or so. And, the BMA was also fairly unimpressed with the spending review, despite the fact that the Department of Health and Social Care fared a lot better than many other government departments did. The BMA says a budget rising by 3% is not enough to deliver sustained improvements to services and the kind of uplifts that, they want to see to the GP contract over the coming years. The BMA is now looking to the 10-year plan to provide real assurances around the level of funding that will be coming into general practice over the coming years, particularly in the context of that big new contract that they've agreed to negotiate with the government. And as we were talking about earlier, before we came into the recording studio, what's in the 10-year plan will absolutely set the parameters for the big new GP contract. That contract will have to be retrofitted onto the 10-year plan's aims. The BMA GP Committee is betting the house on a big contract reform to set general practice up for the future and to ease some of the current pressures on the profession. But whatever it does will have to fit with the 10-year plan. So the moment that plan lands on their desk is going to be a huge one for the GP committee.
Ultimately, I think what's in that GP contract is going to have the biggest impact on general practice day to day when it comes to all of this, isn't it? But basically, all of these things that we've been talking about today are likely to feed into those contract negotiations, aren't they? They're going to be what the government wants to get out of general practice as part of a new contract. So taken all together, this all sounds like GPs are going to be quite front and centre in the 10-year health plan, doesn't it? Do you think it's all going to be positive for general practice?
I was once told that when I wrote a news analysis piece or a feature, I was banned from concluding with a line that was any version of "we'll have to wait and see." But I think ultimately that's kind of where we're at. The prospect of more money going to the front line from reforms in the 10-year plan sounds promising. The shift of more funding and services into the community and potentially into general practice sounds promising. The prospect of a health service with more freedom to innovate locally sounds promising, and potentially the control for providers could be a promising thing. But ultimately, there's a long way to go to find out what it all means for general practice. I mean, how will the 10-year plan shape GP contract reform that we just mentioned? What will the 10-year plan mean for the future of the partnership model? What will it do to address the massive problem of GP unemployment and sort of underfunding of general practice, which, as we've said, the spending review doesn't look to have corrected, and the 4% rise for GP pay this time, plus the wider sort of funding agreement in the contract, doesn't seem to have addressed. So there are a lot of unknowns, but there is also some reason for optimism.
Yeah, I think that's the position I am with all of this as well. There's a lot of GPs I've spoken to do seem perhaps more positive than they have done for a long, long while. So that's really good. But then we've got to remember we're coming off the back of an absolutely terrible period where there were no contract agreements, like funding was even worse. It's not hard to get to a more positive position than we were under the previous government. The GP contract's going to be a big issue, and that's at least a year, if not two, away. So how this all really shapes up for general practice, it really does remain to be seen, to use that phrase. I think we do need to be optimistic, but the reality is this is going to be a really tough thing to do. There's not loads of new money to deliver on this. The government is really banking on that 2% efficiency gain I mentioned earlier. There's no uplift to capital funding. Jim Mackey has previously said they're going to have to sort out a new public-private finance mechanism to deliver on premises. I saw a headline in the Times at the end of last week saying NHS to cut waiting lists by directing patients to GPs for treatment. It was basically talking through all these things that we've been talking about today that came up at the NHS Confederation conference, More Care in the Community. But, my first thought when I saw that headline was, where's the space to do this? Estates and GP premises are a major problem that needs sorting. As we've talked about so often, there are thousands of GPs who either can't get a job or can't get the amount of work that they want to. Those fundamentals really need fixing before you can start farming out patient appointments to general practice. It's hard to see how you can start reshaping services with some of those key issues unaddressed. And obviously, there's some parts of the country that are much more badly affected by these issues than others, often the most deprived parts of the country. We're talking today about this all being something new, but people have been talking about the need to move care out of hospitals and into the community and focusing more on prevention for years. Successive governments, and over that time what we've seen is spending on acute care rising and spending on primary care and prevention falling. What is going to be different this time? Is it going to work? I watched a session where Claire Fuller, the primary care medical director, was talking, and she described what they were aiming to do as doing everything everywhere all at once. It obviously is the right thing to do, and it could be really positive to general practice. But that's going to bash up against the realities of tight funding, the realities of political commitments around cutting waiting lists, which will inevitably become more and more of a priority the closer we get to an election. And also, the elephant in the room is social care and local government funding. It doesn't seem likely that social care is going to get some massive funding boost anytime soon. Local authorities are increasingly in the red. How do you really do neighbourhood working without those local authority services in place? But on saying that, I think that the stuff we've spoken about today around funding flows is actually really encouraging. Obviously, we need to see the details and all of that. But I was remembering a King's Fund report about why this shift to community hasn't worked in the past. And actually, we had Becky Baird from the King's Fund on the podcast, and she was talking about the fact that all the incentives, all the funding flows, all the system, basically, it needs to line up in the same direction around the vision of this to get it to happen. And what we have heard so far suggests that could be the case this time around. So it might actually make this shift possible where it hasn't happened in previous attempts. Let's just hope so anyway. Before we go, we've just got time for our good news story, which this week is about those GPs who were recognised in the King's Birthday Honours last weekend. Midlands GP Professor Bola Owolabi, a former guest of this podcast who was recently appointed as the CQC's Chief Inspector of Primary Care and Community Services, received a CBE for services to reducing health inequalities. Professor Owolabi, who takes up her post at the CQC this summer, is currently the Director of the National Healthcare Inequalities Improvement Programme at NHS England. Dr Mike Prentice, who also works at NHS England, received an OBE. Dr Roger Morris, Professor Jaspel Tagar, Professor Louise Dubras, Dr Modupeola Obelanade and Dr Alistair Roves were all awarded MBEs. And Dr Harvey Sampson received a British Empire Medal. I hope I pronounced everyone's names correctly there. Congratulations to all of those GPs. I always enjoy writing this story twice a year when you include the New Year honours, because it's a good news story and we always need more of those. And it also gives me a chance to look up all of these people, and it makes you realise how much diversity there is in general practice and some of the amazing things that GPs do for their patients and their communities. So you can read more about all of those GPs and what they were recognised for on our website at GPonline.com. Well, that's it for this week. Thanks so much to Nick, and thank you for listening. I'll be back next week, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.